In this lecture, I will talk about EUS-guided radiofrequency ablations of pancreatic tumors, including our experience in that field. Before going on, I'd like to show you very short videos about some of our cases. This is a 35 years old male with frequent attacks of severe hypoglycemia necessitating ICU admission. It is so frequent, occurring 1 to 2 or 3 times per week for many years, and he was diagnosed as insulinoma, and endoscopic ultrasound showed a small, well-localized tumor at the genu or the neck of the pancreas. It is here, we are now scanning from the stomach, and this is the confluence of the splenic, superior mesenteric, and portal vein. And this is a problem for the surgeon because here is the confluence, this is the splenic, superior mesenteric, and forming the portal vein going to the porta hepatis. This is a problem for the surgeon because what type of operation will be done? Is it extended Whipple to remove the head and the neck, or it is distal pancreatectomy to remove the body and neck and the tail? So here we should use intraoperative sonography, which is not available in many centers, or to do tattooing, which is also not available in many centers. So we are obliged to do a major surgery for a small, mostly benign tumor. Insulinoma is mostly benign, very rare to metastasize and very slowly growing. So sometimes we do major surgery for a small benign tumors. This is another case of middle-aged female complaining of dull aching epigastric pain, not responding to the usual spasmolytics and PPI, and here endoscopic ultrasonography showed a very small tumor in the region of the pancreatic body. This is the left kidney, and this are the splenic vessels, so splenic artery and splenic vein, and here this is the left kidney, and this is the region of the pancreatic body, and this is a very small tumor, about 10 millimeter, 1 centimeter, and it is a non-functioning neuroendocrine tumor, but producing pains, so it should be surgically removed. If it is asymptomatic, we can follow it up if it is less than 1 centimeter as this lesion, but it is symptomatic by producing pain. So here the operation is distal pancreatectomy, which again we are doing major surgery for a very small, usually benign tumor. This is another case of complex cysts in the region of the pancreatic tail, because this is the spleen, and now the region of the spleen. We are scanning from the gastric fundus, so this is the tail of the pancreas, the tip of the tail of the pancreas, and here this is a very dangerous cyst because it has mural nodules, very well-defined mural nodules, more than 5 millimeters. This is a grave sign. This is one of the risk factors according to Fukuoka Consensus 2012. So this should be surgically removed. It is a small cyst, it is about 2 centimeter cyst. But we should do distal pancreatectomy and sometimes even with splenectomy. So what I'd like to say that in many instances we are obliged to do major surgery with high morbidity and mortality, even in best centers, for small, benign or potentially malignant tumor. Whipple operation carries a mortality of 5 to 10% in best centers. Morbidity is about 30 to 50%. Distal pancreatectomy has an incidence of leakage rate up to 30%. Enucleation of the tumor have an incidence of fistula formation up to 30%. In addition, patients may be poor surgical risk due to comorbidities, or patients sometimes refuse major surgery. So other modalities should be searched for. Why not radiofrequency ablation as we always do in hepatic focal lesion? The basic technique for radiofrequency ablation was described over a century ago by D'Arzonval, who in 1891 first demonstrated that when radiofrequency waves pass through tissue, they produce an increase in tissue temperature. And in 1910, Beer described a new method for the first time for treatment of renal bladder neoplasm using radiofrequency ablation through a cystoscope. So why not to do radiofrequency ablation of pancreatic tumor using endoscopic ultrasound? It's very easy, not so easy, but it is possible, very possible, to use the endoscope, scanning the pancreas and localizing the tumor, and then introduce the FNE, the radiofrequency needle, and applying a power about 50 to 60 watt for few seconds, 10 seconds for example, and then burn the tumor. Okay, when the temperature inside the tumor reaches 42 to 45, thermal injury starts. When the temperature reaches 46, there will be irreversible damage after 16 minutes, after 1 hour. When the temperature is raised to 50 to 52, there will be irreversible cellular damage after 4 to 6 minutes. When we reach 60 degrees centigrade, there will be instantaneous cell death, and when we reach 100 degrees centigrade, boiling point starts. So the ideal temperature is between 60 and 100 degrees centigrade. So here we'll introduce radiofrequency waves, which will, while it is passing through the tissue, it induces heat production. So what is the potential application of radiofrequency ablation? Is pancreatic tumors, pancreatic duct adenocarcinoma, and neuroendocrine tumor or cystic neoplasm. We may do it in hepatocellular carcinoma or liver metastasis, also through the endoscopic ultrasound, or metastatic lymph node, or GIST tumor, tried in GIST tumor, tried in adrenal gland tumor, and also tried in celiac plexus neurolysis to distract the nerve endings instead of injecting alcohol. And here I think the most important application and the most useful application is pancreatic neuroendocrine tumor. We apply it in the pancreatic neuroendocrine tumor less than 2 centimeters. If more than 2 centimeters, it should be surgically removed, because by then it has a high malignant potentiality, but in surgically fit patients. But if the patient is surgically unfit, we can try radiofrequency ablation in neuroendocrine tumor more than 2 centimeters. And the idea here is to apply it in insulinomas, gastrinomas, lipomas, somatostenomas, because insulinomas are mostly benign. And if I burn 80% of the tumor, I got rid of 80% of the symptoms and 80% of the problem. So it is ideal, and the insulinoma at the end is a benign tumor. So if I had applied radiofrequency ablation to an insulinoma, and even I burned half of the tumor, or 70% or 80% or 90% of the tumor, the patient was relieved by about 90%. So it is ideal to apply in insulinoma and gastrinoma. I can apply it in pancreatic cysts like IPMN or mucinous cystic neoplasm, and the cyst by then should be aspirated to be 1 centimeter in diameter, and then apply radiofrequency ablation. The second indication is pancreatic adenocarcinoma, but it is still palliative. Pancreatic cancer may be resectable, should go for surgery, borderline resectable, or locally advanced and resectable, or metastatic. I can use it in locally advanced and resectable for palliation instead of chemotherapy or with chemotherapy, because when I use both together, they augment each other. They augment each other. They, radiofrequency ablation, make the tumor more sensitive and more affected by chemotherapy. So the combination of both is an augmentation, not just summation. It may decrease the size of the tumor. It may increase the resection rate, but not proved till now. It may reduce metastasis, and it may be used for local recurrence after surgery. It has many advantages. It is minimally invasive. It is not a major surgery. Can do it twice and to the third and fourth times. No cumulative toxicity with chemotherapy. Short-term recovery after the procedure. Most of the patients discharged. All our 5 patients done in Egypt were discharged after the maneuver in the same day, after 2 to 3 hours in the recovery room, and then discharged home. It can be combined by chemo and radiotherapy. But it has some adverse events. It may injure nearby structure, may damage nearby structure like the distal CBD and the duodenum. Or in the pancreas, it may produce pancreatitis. If I burned near the main pancreatic duct, it may produce fistula formation, or it may produce ascites. The largest study for radiofrequency is the French multicenter study by Marc Partey and Marc Giovannini. Patients included are poor surgical risk patients, planned for 30 patients over 2 years, follow up after 1 year. They included mucinous adenoma, IPMN, and neuroendocrine tumor. They experienced 3 complications out of the 30 patients, complication about 10%, and surprisingly enough, the first 2 complications occurred in the first 2 patients. 1 patient of pancreatitis, affected pancreatitis, 1 delayed small bowel perforation, and these were the first 2 patients, and the third complication is 1 patient complained of pancreatic duct stenosis. So they changed very early the protocol of the study. They gave prophylactic non-steroidal anti-inflammatory drugs like in ERCP. They give antibiotic prophylaxis, and they avoid radiofrequency ablation close to the pancreatic duct. At 6 months, there is significant response in about 82% of the patients. 14 had complete necrosis or disappearance. 4 had a diameter decreased more than 50%, and 2 had a diameter decreased less than 50%, and 4 had complete failure. At 12 months, no recurrence occurred in responder patients. In the following slide, I will show you the Egyptian experience in 5 patients. We did 5 cases, 2 cases of unresectable pancreatic duct adenocarcinoma as a palliative therapy, and 3 cases of incidinoma. 3 males and 2 females, mean age was 42 years. 8 sessions was applied with total of 8 sessions with total of 16 passes. 2 passes or 2 burns for each patient. 1 session for 2 patients with adenocarcinoma, 1 session for 1 patient with incidinoma, 2 sessions for 1 patient with incidinoma, and 3 sessions for 1 patient with incidinoma. We used 19G cooling Eus-Rfa needles from Taiwan. This is the video of one of the cases of adenocarcinoma for palliative purposes. Yes, this is a mass, a very large mass in the head with extensive collaterals due to compression and occlusion of the portal vein. We use radiofrequency ablation. 1 pass, 1 session, 2 passes in 1 session. This is the first pass here. It is becomes whitish due to necrosis, and this is the second pass in that session. Yes, I should avoid intervening vessels, and I should avoid the pancreatic duct. This is, I think, the common bile duct, and I am away from the pancreatic duct, yes, and this is a needle, 19G needle, and I introduce it, and the needle length is 1 centimeter, and then here it is in the middle. I should go further. Yes, I think this is a nice place to start. Radiofrequency ablation, and then I applied. Yes, now this is ablation started. Yes, and you notice here there is whitish dots, and the area becomes whitish due to vapors from burning of the tissue. This means successful ablation, exactly as ablation of the liver. This area is gases or vapors from burning of the tissue. Okay, this is an interesting case. This is the first case with insulinoma. Our third case, which is the first case of insulinoma, a 37-year-old male refusing to do major surgery. And here, this is a tumor. And we did it in a conference. Yes, and this is the tumor, very small. It is about 9 by 10 millimeter. And here it is located at the confluence. We apply it for 40 watt for 10 seconds. Yes, here this is the tip of the needle. Yes, this is the tip of the needle. It's very nice. And then we will start to apply radiofrequency ablation, 40 watt for 10 seconds. When there is haziness or waves, then we start ablation. Yes, now we start ablation. Here, this is haziness, means that we start ablation, and here area is becomes more and more whitish due to gases. Okay. No major complications or mortality for mean follow-up period of 12 months, range 2 to 30 months. In the 5 cases, there is post-procedure gastric pains. In the last case with insulinoma, decreased gradually over the following 3 weeks and not necessitating hospital admission. And let us give some details about the outcome of our patients. There is decrease in about 50% of the volume of both cases with pancreatic adenocarcinoma. However, no downstaging allowing surgical excision occur. So it is just for palliative maneuver. Let us follow up the cases of insulinoma, the 3 cases of insulinoma. The first case, no bouts of clinically significant hypoglycemia over the 4 weeks following radiofrequency ablation. However, over the following months, there were 3 bouts of hypoglycemia necessitating intravenous glucose infusion. So another session of radiofrequency ablation was planned by moving shot technique. Moving shot technique is to introduce the needle to the most distal part of the tumor and then apply a pass and then withdraw up and apply another pass, so burn more and more area of the tumor. There is recurrence. Despite this, there is recurrence of hypoglycemia after 3 months, but in a milder form, shorter duration, less severe and less frequent. Despite that, we decided to apply a 3rd session. After the 3rd session, there is excellent response and no further bouts of hypoglycemia and no further ICU admission or significant hypoglycemia. The second case required 2 sessions. The second case of insulinoma required 2 sessions with complete relief of the attacks of hypoglycemia with complete cure. Regarding the 3rd case of insulinoma, no further bouts of hypoglycemia for 1 month after only 1 session. It is done 1 month ago. So, my take-home messages are: EUS radiofrequency ablation is a promising technique for small neuroendocrine tumors to avoid major surgery with significant morbidity and mortality even in best centers. Appears of great value in small, mostly benign functioning neuroendocrine tumor as insulinoma. As I told you before, this is an idea because insulinoma is benign. If I burn 80%, then I will get rid of 80% of the symptomatology, and even the remaining part is a benign tissue, not known to metastasize or to be an aggressive tumor. It is especially indicated in surgically unfit patients or patients refusing surgery. However, more comparative studies are needed before recommending EUS radiofrequency ablation as an alternative therapy to surgery for operable pancreatic masses or as an alternative to chemotherapy in inoperable pancreatic masses. And thanks for your attention.